The Surgical Anesthesia ICU is a multi-specialty critical care unit. You'll have to get along with a lot of other people if you want to take the best care of your patients. This is your field guide to playing well with others in the ICU. Our nurses and respiratory therapists are part of our team. Include them when you're rounding. Use their time with your patient and their experience to your benefit. When you change an order outside of rounds, give the nurse or RT a heads up. You shouldn't change the pumps or vent settings yourself. Instead, communicate that so everyone stays in the loop. Working with all these services, admissions can get a little confusing. Here's what you need to know. Never refuse a patient. If you don't think a patient belongs here, talk it over with your fellow or attending. Usually, we're happy to watch a patient if the primary team doesn't feel comfortable sending them to the floor. Rarely, we do get an admission that wasn't meant for us. Always take care of the patient first and sort out the politics later. Let's talk about our roles with each different service we work with. You might want to write this next part down. We're the primary service for OB, MFM, orthopedics, gyn-onc, hepatology, and any other service that would like us to, including direct admissions from outside institutions or the emergency department. We cover general surgery, minimally invasive, colorectal, surg-onc, urology, ENT, thoracic, and transplant. We generally do not cover plastics, trauma, and emergency general surgery, unless they really want us to. You got all that, right? When you admit a patient to our service, change the attending to our attending, the service to anesthesiology, and the pager number to SAICU at 2000. When you're covering, the primary service and attending will stay the same, but change the pager number on the banner to our pager number. The ICU team writes all the orders for all our patients, including admission orders. Use the Anesthesia ICU Admit order set. There are a couple exceptions to writing our own orders. Transplant surgery writes their own immunosuppression orders. And rarely, other services may want to put in something specific, like a CAT scan looking for an abdominal abscess. That's fine, as long as it's communicated with you. When you're covering a patient, communicate with the primary team early and often. The better you know each other, the easier it is to take care of your patients. If there's a significant change with a patient, get in touch with the most senior person on the service as soon as you can. If you ever have a difference in opinion between you and the surgical team, call the attending to clarify. If you're called with something that sounds like a surgical issue, like a leaking vac dressing, go evaluate the patient. If you decide that there's a surgical solution, call the surgery resident so that they can help you out. We share our space here with a SAICU trauma team. Sometimes they ask us for help with procedures like intubations. We like to help if we can. This works both ways, so don't be afraid to ask them for help either. When a patient leaves the ICU, the accepting service should enter the downgrade order. That way, we know that they know their patient is coming back. If any patient in the ICU needs immediate help, even if they're not our patient, step in. The primary team might be pretty far away, so we can provide life-saving interventions and make sure someone notifies the primary team. Having a loved one in the ICU is stressful, and you're going to see a whole range of responses from friends and family members. We try to have a daily conversation with our patients or with their designated surrogates. This isn't always the person in the room. Check the chart or ask the patient's nurse. Document who you spoke with in your progress note. These family conversations can be challenging. These steps might help you as you're starting out. First, give the surrogate a chance to ask questions or bring up concerns. Be empathetic and try to validate their issues. Something that might seem trivial to you may be very important to them. If you don't have answers to their questions, it's fine to say, "I'm not sure," and offer to find out. Second, once questions have been answered and concerns have been addressed, ask if they would like an update. Not everybody does. If they say yes, be clear and concise. Third, document who you spoke with in the chart. A word of warning before we finish. If a patient or a surrogate is unhappy with their care, watch out. Never speak poorly about another provider. Listen to their concerns and tell them that someone will follow up with them. Then, notify your attending right away. If you're ever in doubt about anything in the unit, ask your attending. You're here to learn, and they're here to help you.